Hello, thank you so much for joining me. I'm Dr. Lewis Hassel from the University of Oklahoma Health Sciences Center, and I'm going to spend the next hour or so talking about some of the differential diagnoses around certain core kinds of cases in GI pathology. This was part of a preparatory review course for U.S. Trainees preparing to take the pathology boards, but I think it can serve as a useful purpose for trainees at any level and even for some practicing pathologists who want to review some of the issues and core situations in GI pathology, along with a few fringe cases that may be a little bit challenging. And we've got some wonderful MCQs that have been helpfully written by Aisha Siti, my colleague at Cincinnati, and Neha Baharsti, who's also a trainee. So I'll try to show you those questions as we go along. So let's go first right to the cases and get started with these. This won't be necessarily a walk on the beach, but it will be hopefully useful. And I'll just refer you to my playlists, which do include a number of things sort of focused on GI pathology as well as other areas of pathology where I feel comfortable, as well as some interviews with people over various topics in other areas, and a few additions from other people's videos as well. So let's start with the first case. This is a 65-year-old man who has a biopsy of the gastroesophageal junction, something that we see fairly frequently. And as you can see, we have some squamous mucosa, but we've also got fragments of glandular epithelium. And here we see areas where the glands are a little bit compressed and maybe look a little hyperchromatic. Overall, this sample itself is somewhat hyperchromatic just because of the rather intense hematoxylin staining. But in fact, as we go looking down on this area, we don't see right off any definitive evidence for intestinal metaplasia. A few little vacuolated spaces here that might raise concern. In my practice, we don't generally use the Alcian blue PAS stain, but that can be useful for demonstrating the presence of intestinal type mucus if you need it. However, usually our H&E is sufficient. And in fact, in this case, we have this area down here where you see very nicely that we have these dilated, rounded spaces compressing the adjacent cytoplasm, and the mucin has a slightly blue hue, which is quite characteristic for goblet cells. So once we've established that there is intestinal metaplasia present, and even sometimes in some cases before that, we want to decide whether or not we have dysplasia. So in general, what we like to see is the extension of cytologic atypia to the surface. And so here, an area here, you can see a little bit of opening of the nuclei, some stratification. So this kind of an area might lead you to be suspect of low-grade dysplasia. I don't have any particular length or requirement of lineal extent to call something low-grade dysplasia, but I do like to see it on the surface. Here's another area right here where we see some loss of polarity, some rounding up of the nuclei that begin to show features on the surface. However, we don't really see significant architectural distortion, and there's no high-grade pleomorphism noted here. So at most, we're talking about low-grade dysplasia. For comparison purposes, well, actually, let's go back and take a look at the MCQ here. Just to review, what is the criteria for Barrett's esophagus in the United States? As most people guessed, it's a columnar epithelium that is proximal to the esophagogastric sphincter, at least 1 centimeter, and the presence of intestinal metaplasia. Now, in Europe, that criteria is a little bit different, but in the United States, that's what we use. So let's look at what we've got here on the left. For comparison, these two side-by-side slides, here we can begin to see not only some surface atypia, but we're beginning to see a lot more inflammation and more nuclear pleomorphism, even at low magnification here, loss of polarity. And also you see the variation in size of these glands. So this is looking to me like we're going to get towards high-grade dysplasia. And once you start to see that change, then there's another very subtle change that can creep in on you if you're not aware, and that's these small glands with seemingly shrunken cells. They don't look very worrisome from low magnification. They just look like dilated glands. But in fact, when you come into higher magnification, you can see nucleoli, rounded up nuclei, and even, as we see here, some extension around strands of the muscularis mucosa. So starting to look like this could even be an invasive set of glands for esophageal adenocarcinoma. Now, obviously, it's not beneath the redundant or reduplicated layer of the muscularis mucosa into the submucosa, which is nicely defined here with these submucosal glands. And we can look at the other areas in here, and I think you'll see also here a pretty high-grade nuclear pleomorphism, disorganization of the glands. So calling this high-grade dysplasia should not be a challenge for you. And I think that's probably the main features we wanted to highlight here. You can look at these other areas at your leisure. And I'll just mention that the links to all these slides will be provided in the description of the video, so you can come back to these slides and MCQs and look at them at your leisure. So this case, in contrast, again, we see a reduplicated muscularis mucosa, submucosal glands, an endoscopic mucosal resection. But here we, again, just see columnar mucosa, a little bit of early intestinal metaplasia here, perhaps, some goblet cells, maybe the beginnings of some atypia there. So that fragment seems to be okay. And then we come over to this one, which looks a little bit busier. But again, we see here are these deep glands. And notice here we don't have that kind of high-grade atypia that we saw in the other sample. But we do see, again, some stratification, some hyperchromasia. Now, we don't grade the dysplasia based on these subsurface glands, although they can certainly harbor dysplasia, but it's the presence of dysplasia on the surface epithelium that is what we really like to see to be confident in our diagnosis. And then I think there's a nice area up here, which shows this again quite nicely. Hyperchromasia, the beginnings of some loss of cytoplasmic distinctions between the mucin droplets here in this area, a little bit more atypia there. And so the beginnings of a nice low-grade dysplasia here for contrast with the other case. And there it is, right there. Another area right here shows you again this loss. A little bit of architectural atypia here, but not the high-grade changes that we were seeing before. So with that, we'll go on to, let's see, I don't think we had an MCQ for this case. Let's just see. Oops. Yeah, these were all signatures for low-grade dysplasia. Okay, so let's go on to the next case and just, oh, well, before we do that, just for board purposes, being very clear of what the definition is and what you can say pathologically as opposed to what you should not say. You should not generally diagnose Barrett's esophagus. You should just describe what's present and allow the clinical pathological correlation of the biopsy provider to decide if it's Barrett's or not. And understanding that once we get dysplasia, you're giving that patient the diagnosis of higher risk of cancer and potential changes in their management. Once you diagnose Barrett's, you're also going to change their management in terms of surveillance. So that once we detect Barrett's, that's going to get surveillance more frequently. Once you detect dysplasia, that's either going to get ablation or a surgical excision. Once you get high-grade dysplasia or invasive carcinoma, then of course you're looking at the possibility for treatment that may be more serious if it's beyond stage 1A. Okay, so let's go on to the next case. This is a 55-year-old man with a mass in the tail of the pancreas. As you can see here, we've got nice pancreatic parenchyma here, interspersed with fat, some islets, some acinar parenchyma, maybe even a few small ducts we can identify. There's not a lot of ductal epithelium here, but I don't think we even had any pannin. Well, here's a nice little central duct without any evidence of glandular or cellular enlargement. Here's some more ducts here. Again, I don't think I would call this pannin. These are a little bit taller than normal, but they are not into that stage 1, grade 1 pannin. But of course, our lesion over here is this. It's a rounded, well-circumscribed nodule with a lot of sort of nested cells, but a fair degree of discoherence. This looks a lot like it might be a neuroendocrine tumor, but it's not quite exactly the well-differentiated pattern that we typically see. We do have islands and nests of cells, but they're a little bit discohesive. As we look a little further, we see that some of them begin to have kind of some glandular differentiation in areas, maybe little areas like that. A lot of intervening dense fibrous tissue. And then down here, we see very clear-cut glandular differentiation, and the cells look cytologically distinct from these more darkly staining neuroendocrine cells. In contrast, these cells have somewhat more open chromatin, small nucleoli, a brush border type of appearance along some areas here, but they seem to be intimately associated with some of these probable neuroendocrine cells. So is this a part of the tumor? Is this encaptured captured glands that have come as the tumor has engulfed pancreatic parenchyma and retained the ductal component? Well, I think the overall architecture here is not particularly lobular. It's more of a diffuse area here that looks like we may have a mixture of a glandular component. So that puts us into the category, assuming that we've got neuroendocrine differentiation, which you'll have to agree with me that, or have to take my word for it, that we do, that this is a combined neuroendocrine, non-neuroendocrine tumor, provided these cells don't show neuroendocrine differentiation, which they did not. And we'll show you that free feature perhaps later. So what qualifies as a mixed neuroendocrine, non-neuroendocrine tumors? So let's see, if what? The minor component is at least 30% of the tumor. That's the cutoff. 30% is required in order to classify this as a mixed neuroendocrine, non-neuroendocrine tumor. So that's a very good, correct answer there. What do we do if we have a 10% component? Well, we use a different terminology. We don't call it mixed. We just call it a neuroendocrine tumor with minor glandular elements or a minor component of adenocarcinoma or whatever. In general, these tumors tend to behave according to the hallmarks of the worst differentiated component. So if the neuroendocrine tumor is the higher grade and more aggressive tumor, that's going to be what's going to guide prognosis and so forth. In this case, our adeno component is quite well differentiated. Not even completely sure that it's a carcinoma, but certainly we don't have other terms for a low-grade glandular lesion like this. And it's certainly dispersed in an invasive pattern. So I think we would call this an adenocarcinoma neuroendocrine tumor. And depending on the grade of the tumor, 1, 2, or 3, based on Ki-67 and mitotic index, then we would report that out. So neuroendocrine tumors of the pancreas are typically most frequently encountered in the tail. They are not hormonally active. And they're only associated with these syndromes in maybe 20% of cases at most. So this is the pitfall here. And also they are graded as grade 1 if Ki-67 is 3% or greater. And of course, they are increasing in frequency. Witness Steve Jobs and other notable people, Ruth Bader Ginsburg and others who've had neuroendocrine tumors and suffered devastating consequence and loss of life due to them. So things to remember for the boards: know your distribution nomenclature and associations. Know how they're going to behave and their unpredictability. Know how to grade them. Grade 1, less than 3%. Grade 2, 3 to 20. Grade 3, greater than 20. Carcinoma, frank carcinomatous features. And then the syndrome associations, MEN, NF1, and so forth. Von Hippel-Lindau, those associations are present. All right, well, sort of staying with a similar theme, let's move over to the stomach. And here we see a nice set of biopsies, actually another endoscopic mucosal resection. We have some very accomplished surgeons who are good at that. And maybe continuing this combined theme, we have certainly what looks like a neuroendocrine tumor here, but also some glandular elements here that have been at least associated with it. But in contrast to the previous situation, these are all very well differentiated. They show nice goblet cells. They don't show dysplasia. So is this just an inclusion? Well, it's kind of hard to be sure. But one thing to note here is that we have goblet cells. So we're in the stomach, as we can witness over here, where we've got some sort of pyloric or antral type mucosa with, again, intestinal metaplasia. But we've got significant intestinal metaplasia due to autoimmune chronic gastritis. And so that change is setting up the endocrine drive that stimulates the enterochromaffin cells to become hyperplastic. And you can see some of them here and at the margins elsewhere. And they produce multiple small neuroendocrine tumors of varying size. And here we can see this nice nested pattern, granular cytoplasm, uniform round nuclei, small central nucleoli, sort of salt and pepper pattern nuclei, chromatin, and some superficial extension into the lamina propria and submucosa. So this is an example of sort of a type 1 neuroendocrine tumor, in this case with this minor association of the glandular component. And in fact, these excisions were from several different sites. So they're not all the same site that's been sliced and diced. They're actually several different mucosal resections, showing you that this process is multifocal, and each one of these is essentially a separate neuroendocrine tumor arising in this situation of enterochromaffin cell hyperplasia, which you can see here in some of the adjacent structures. So which of the following are true regarding atrophic gastritis? Well, in fact, there is an environmental type of atrophic gastritis that has a significant association, not in 35%, but in up to 75% of cases. So that's a little bit unusual. The extent of intestinal metaplasia is a risk factor in the development of malignancy. And the atrophic gastritis is mediated by a combination of cell-mediated immunity as well as antibody-directed damage. Anemia is generally a late marker rather than an early marker. So the correct answer here is that the extent of intestinal metaplasia is the extent is what's going to determine the risk of malignancy, and that it's not just antibody mediated. You have a combination of etiologic factors there. And with regard to well-differentiated neuroendocrine tumors in the stomach, very commonly associated with, all of these are true, commonly associated with atrophic gastritis, enterochromaffin cell hyperplasia, which you've mentioned, and the drive for that is achlorhydria with hypergastrinemia, and they may be multifocal and recurrent, but metastasis is extraordinarily rare. So things to remember from that. We'll talk a little bit more about gastritis before we summarize things here. So my approach to other gastritides is to look first at the distribution of the inflammation. And if this was a biopsy I was looking at, I might say, well, it looks fairly normal. We've got some body mucosa here with just a few scattered lymphocytes and maybe a piece of antrum here with, again, just a slight, very sparse increase in lymphocytes. So that's my trigger to go look at higher magnification. But oftentimes the inflammatory infiltrate, superficial, fairly dense inflammatory infiltrate, is diagnosable at low power as being 99 cases out of 100 due to Helicobacter pylori. So in this case, we went to higher magnification, and well, guess what? Here are these microorganisms. Nice, long, rod-shaped organisms, fairly straight rather than the more typical seagull shape that we often see. And here we can see that the inflammatory infiltrate is quite sparse. There's very little, both intraepithelial or otherwise. And then we can see, again, a few scattered organisms. So we usually in our laboratory don't have to do immunohistochemical stains for microorganisms, but the times when I would do it would be atypical cases like this, where the infiltrate was sparse. I wasn't sure if these were really the culprit organisms or if these were commensals that just happened to be there. And situations where maybe there's been prior treatment, or there has been a situation, immunocompromise or other circumstance that might lead to suppression or low numbers of organisms. So just to review our MCQs here, which of the following should alert you to the possible presence of non-H. pylori, non-Helicobacter, non-pylori strains of Helicobacter? Well, any of these actually is the right answer. So pediatric age group, those are more likely to get atypical variants, sparse or lymphoid infiltrate and no neutrophils, and these longer organisms. So in fact, our incident case here is Helicobacter hillmanii, a variant that doesn't have quite the same virulence as Helicobacter pylori, doesn't provoke quite the inflammatory response, but still does have some association with risk of malignancy and ulcers. And fortunately, fortuitously responds to the same therapies. Helicobacter pylori presents oftentimes with minimal symptoms, maybe just mild dyspepsia. Abdominal pain is uncommon, and usually does not require special stain. So if your hematoxylin is good, you should be able to see this organism in most all cases if you look. And of course, it can be detected with non-invasive testing, such as urease breath testing, stool testing, and serologies as well. But it typically requires a triple antibiotic therapy to fully eradicate. So there we go with that one. So with regard to gastritis, understanding the pathophysiology and the distinctions between the relationships between atrophic gastritis versus superficial Helicobacter type gastritis, and the differential considerations. If I see a relatively normal biopsy, I always look for eosinophils because they can be present in a slightly increased number in patients with symptoms, but maybe not full-blown eosinophilic gastritis. And I report them in terms of counts when they have numbers greater than 5 or 6 per high power field. And then, of course, knowing which bugs to be looking for and when they're not, when you need to be looking further to potentially detect them using immunohistochemical stains or other specific stains. Okay, well, let's move on in the stomach to polyps. And of course, a variety of polyps can occur in the stomach. Just at low magnification, this looks like a very hyperplastic polyp with probably mostly foveolar cells, which we can see here have a fairly abundant mucinous cytoplasm. But we're also seeing a few cleared out cells, sort of almost not goblet cells per se, but maybe some are goblet cells. So there can be dysplasia, there can be intestinal metaplasia that can occur in these foveolar adenomas or hyperplastic polyps, as they're often called. And this one is somewhat unique because of this vacuolar appearance in areas. And as you come back and search around in these areas, I think you'll begin to see that there are areas where we have atypical cells like this one or like this one. that are occurring in this epithelial compartment. And then having recognized that, I hope that you'll come back and study the transition between those kinds of areas, those kinds of cells, and the more serious problem that we see right here, which is actually signet ring cell carcinoma or poorly cohesive carcinoma involving the lamina propria. So a situation where we have potentially an in situ component to that tumor, not commonly detected, as well as this lamina propria invasive component of the tumor, and so forth. So this is one of the several types, a very insidious type of gastric carcinoma, and certainly finding it in this sort of a setting would warrant much more close scrutiny to see if there was evidence of spread and the potential need for treatment. I certainly in this situation would probably do my treatment panel testing to determine molecular type and so forth. And you also want to be alert for the possibility of other syndromes associated with these poorly cohesive tumors. So particularly hereditary diffuse gastric carcinoma, this type of carcinoma can be a hereditary linked tumor. So in someone with a first degree relative with either breast or gastric carcinoma, you ought to be concerned about looking and seeing if they have a CDH1 mutation. So everybody gets this one right and don't have to worry about whether it's beta-catenin or STAC11. This is clearly the right answer. In terms of other immunophenotypes or other molecular phenotypes, there are several other things to be aware of. So first of all, some gastric cancers are related to Epstein-Barr virus, and so this is the correct answer. While TP53 is occasionally present in gastric cancers, it's not a specific molecular phenotype. And while microsatellite instability is a factor here, it's not the microsatellite stable tumors that you want to identify. It's the ones that have instability or have MSI high, some loss of mismatch repair capability, not RB1. So if you recognize that some of these things were associated, you were close, but you do need to think more in terms of the four main categories of molecular phenotypes in gastric cancers. So things about gastric cancer, molecular subtypes I've mentioned, the genetics associated with both Lynch syndrome as well as with CDH1. CDH1 is an autosomal dominant. It's important to remember, as is Lynch syndrome. The precursor lesions, the polyps, funding gland polyps, the APC mutations can be a cofactor there as well. And then post-treatment issues. We see more and more cases where they come to resection after a course of neoadjuvant treatment, and searching out the occasional hiding cells amidst the histiocytic reaction or amidst the radiation / chemotherapy gastritis is a particular challenge and may require immunohistochemistry or very careful examination to identify those cases. Okay, staying in the stomach, of course, we know that lymphoproliferative lesions occur in the stomach as well as in other areas. This is a gastric biopsy. You can see here we do have some foveolar epithelium, but we have a tumor mass that is invading the epithelial compartment. Here you see some nice early lymphoepithelial lesions. And we have a neoplasm that's composed of dark blue cells and raises consideration for whether or not this is a MALT lymphoma or potentially even a higher grade follicular lymphoma or a B-cell lymphoma. So this is not a hard thing to recognize, but sometimes the thresholds as to when it's lymphoma and when it's just lymphoid hyperplasia can be a little bit difficult. So clonal expansion is oftentimes occurs in the setting of ongoing H. pylori stimulation, but it may not be sustainable because those cases will often resolve completely with anti-Helicobacter treatment. And the immunophenotype in both these circumstances will be similar, where you'll have a CD20, BCL2 positive, and CD10 negative tumor. The diffuse large B-cell tumors would be more likely to be positive for all 4 of these. But at any rate, that's kind of where we are with the low-grade B-cell malt lymphomas there. And in terms of organisms, of course, you all know this is Helicobacter driven, and that's why treating the Helicobacter can oftentimes eradicate the lesion. I would encourage you to come back and just take a look and see how many lymphoepithelial lesions you can identify in this, and maybe send me a nice picture of one if you can take it. In terms of other lymphoid lesions in the GI tract, you do want to be aware that things like Burkitt's lymphoma can occur, other large B-cell lymphomas can occur in other sites as well. And we do have the somewhat unique T-cell lymphoproliferative disorders, particularly involving the small bowel and sometimes associated with sprue-like symptoms or sprue-like situation. Okay, so we're going to move down the small bowel a little bit into the duodenum. And here's a very typical duodenal biopsy. You see the Brunner's glands here. And we can look and see, okay, here's our mucosa, crypts down here, and our villi. But one thing that should strike you right away is the fact that rather than being, 3 to 5 times taller than the crypts, these are closer to 1 to 1 or maybe 1 to 2. They're not quite so pronounced as more typically would seem. So let's look at other areas and see if we have the same situation. Yes, we have a degree of crypt hyperplasia going on here, and some sort of rounding or blunting to some degree of these villi. Here's some maybe a little closer to normal there, but then over here, look and see that these are rather markedly blunted. So blunt villi, is that all we have to look at? Well, what else do we need to think about? Besides celiac sprue, the most frequent other association is autoimmune enteropathy. Now, these other lesions may also occasionally give you villus blunting, not likely eosinophilic enteritis, collagenous sprue, not very often. But the most frequent one to remember is autoimmune enteropathy. And then the question is, do we have intraepithelial lymphocytosis? And I think as you'll see here, we do have a whole bunch of extra nuclei here in the epithelial surface compartment, as well as even down below the surface, that are greater than what we would normally accept as normal, kind of 1 to 5 nuclei. We can look at another area here and again see increased numbers of these small lymphocytic nuclei scattered around every 3rd nucleus in this fashion. And here even, again, somewhat more. So the presence of increased intraepithelial lymphocytes and some degree of villus blunting, virtually pathognomonic of celiac disease in the appropriate setting. But it's not the only sort of thing. So for example, what should also we think about with increased intraepithelial lymphocytes? Well, not tropical sprue. Tropical sprue is not associated with increased intraepithelial lymphocytes. Collagenous sprue may have increased intraepithelial lymphocytes. Crohn's disease, probably not. But certainly the most frequent would be celiac disease. Confirmatory testing, anti-gliadin antibodies, other sorts of things can be very useful and probably should be pursued in this setting to verify the diagnosis. And then, of course, you realize that you're committing a patient to a whole new lifestyle when they have to give up gluten. So you want to make sure that you've nailed that diagnosis down firmly. In terms of questions about celiac disease, classification, staging, pathophysiology, the Marsh system, certainly you should be aware that it exists. We don't use it in our practice, but in some locations and certainly in a research setting, they would use it. And the pathophysiology, the gluten being transformed to gliadin, which then evokes an antibody response, and a combination of antibodies and cell-mediated immunity results in the blunting of the tumor, of the villi. Then just what else causes blunting, different age groups, different sorts of things to be aware of. Okay, well, let's slide up the biliary tract and take a look at the gallbladder. This is a somewhat unusual case because most cases of gallbladder cancer begin as dysplasia. But as we look at this particular case, I think you'll see that we have fairly normal looking surface epithelium here in almost the entire area. But we do have fairly extensive intramucosal, lamina propria, intralymphatic, mural carcinoma with, here you can see a very nice tripolar mitosis infiltrating through the wall. And so is this a primary gallbladder carcinoma? Well, it may be because like other sites in the GI tract, you can get poorly differentiated, poorly cohesive carcinomas that will arise in the lamina propria seemingly with very little in terms of surface involvement. And that may be what's going on here. With regard to gallbladder carcinoma, this is a frequently overlooked and missed diagnosis, unfortunately. Despite the fact that we take these out every day, oftentimes multiple times in almost every US hospital, the frequency with which gallbladder cancer occurs is still very rare. And so as a rare event for most practicing pathologists, it's easy to miss it. If you don't section that appropriate area, if you don't detect the thickening or the firmness in the wall by palpation, you might easily miss an occult carcinoma. Of course, it's always good practice to take the cystic duct margin to make sure that you're not going to have a cancer extending to that part of the margin, and sample any lymph nodes, as that may also help you. Now, is this metastatic or primary gallbladder carcinoma? Well, there's no specific marker that will tell you, hey, I began in the gallbladder or even in the biliary tract. But we can get a general phenotype of maybe CK7, plus or minus some CDX2, plus or minus some CK20 in some circumstances that will give you a clue that it's gastrointestinal. I don't think SATB2 has been used very much in gallbladder carcinoma, so I'm not sure of its reactivity. So let's just see what people thought here about this. Pitfalls in the identification of carcinoma of the gallbladder would be misinterpretation of adenomyosis as invasive disease, under or non-sampling of the gallbladder, Rokitansky-Aschoff sinuses extend to the adventitia. Yes, those can be misinterpreted as potentially invasive carcinoma, especially if they're involved by dysplasia. And so the answer really is all of the above. And in terms of histologic types, in terms of morphologies, the most frequently encountered type of tumor that we're going to see is the intestinal type. Signet ring cell or small cell neuroendocrine tumors or low-grade mucinous neoplasm, these are much less frequent. These all do occur, however, and should be within your differential considerations when you're looking at the gallbladder. Now, I put a couple of extra slides on here just for comparison. Here's an example of adenomyosis, so you can get a feel for, here's the normal gallbladder mucosa, the muscularis, maybe a little bit of adenomyosis here, that extends down a little bit into the muscle. So you could call that adenomyosis, but an adenomyoma is when this becomes more serious and you develop, more extension of the adenomatous epithelium. Notice here that the epithelium is still very bland. There may be some pigment or hemosiderin deposition, or maybe some stone pigment that could be present, some biliary pigments that can be associated with that. And here you see this intermingling of muscle tissue that says adenomyosis. Most frequently, this adenomyoma is a lesion in the fundus. And clinically, radiologically, it can be mistaken for a gallbladder carcinoma. You do want to make sure that here you got a Rokitansky-Aschoff sinus here out here at the adventitia. Notice again that the cytology here is identical to that you see up here. So when you have dysplasia up here, you very easily can have dysplasia down here, as well as in these areas of adenomyosis, which can masquerade as invasive carcinoma. So let's look here at what some dysplasia looks like in the gallbladder, just to familiarize you with that. Here you see conventional type dysplasia, glandular crowding, pencilloid nuclei, hyperchromasia, and no particular change in architecture, maybe with some preserved normal gallbladder mucosal glands here in some areas. Now, when this goes to, oops, that was the next area I wanted to go. When this starts to extend into the wall, this is where the pitfall is, and you can see how if this was all taken over by dysplastic epithelium here in contrast to the normal, you might believe that this was an invading island of tumor. And if it goes all the way to the adventitia, that's another pitfall in terms of making the diagnosis of invasive disease. Once you detect dysplasia, you certainly should go back and section more liberally and very carefully assess the texture and feel of the gallbladder to make sure that you don't have any areas of microscopic or occult invasive disease. We've seen far too many cases of patients who have shown up years later with metastatic disease due to a non-detected gallbladder primary tumor. So the risk factors for gallbladder carcinoma, stone disease, hemolysis, and so forth, and associations in pathophysiology. There is some association with, long-standing inflammatory disease because most patients with gallbladder carcinoma have had their stones in place for quite some time. Non-stone related gallbladder carcinoma, relatively uncommon, but certainly we should think about the pathophysiology in terms of associations with things like Lynch syndrome or with other familial carcinogenesis situations. Another lesion which we don't necessarily think of in the biliary tract is what we illustrate here. Now, this is sort of a cirrhotic transplanted liver, and a sort of an incidental finding. The patient was found to have dilated biliary tract ducts with this intraluminal proliferation, as you see here. And as you can see, the epithelium is quite bland, basal nuclei, sparse amount of cytoplasm, somewhat mucinous, and so looks very banal. But we've got some funky little stromal process going along here as well. And so you have to remember that mucinous cystic neoplasms, along with intraductal papillary mucinous neoplasms and other biliary tract lesions, can occur up into the gallbladder and extra and intrahepatic bile ducts as well. Sometimes, this will occur in the setting where you've got sort of a sclerosing cholangitis or a biliary cirrhosis type of pattern, which appears to have happened here. But the characteristic of this lesion, of course, is identifying the characteristic stroma. And here you see this ovarian-like stroma, maybe even with a suggestion of some luteinization in some of these cells. And this stroma will typically stain with inhibin, with calretinin, with other markers for ovarian-type stroma, hormonal markers, and so forth. And there you see, and sometimes you'll see corpora albicans-like lesions. So what should we know about this? Well, which profile is most common with this tumor? Most frequently seen in the pancreas, in females with this ovarian-type stroma, and they do have the KRAS mutation in many situations. The biliary location is secondary. So biliary in the sense of the hepatobiliary, pancreaticobiliary tree, that would be correct there, but pancreatic versus biliary location. Males do occasionally get the lesion, but much less commonly. In terms of the immunophenotype for the stroma, well, it is typically CD10 positive and inhibin positive. It can be ER positive, but not MUC5AC. So the stroma should not be MUC5AC. Now, the glandular epithelium might be. So a little caveat there, note and read the question carefully, or you may go down the garden path. Okay, so then just to sort of summarize on mucinous tumors in the pancreaticobiliary tree, understanding the variants that we see, intraductal papillary mucinous neoplasms or mucinous cystic neoplasms, so that basic thing, and how to distinguish those on the basis of the stroma. Either one can show varying degrees of dysplasia and invasive carcinoma. Defining invasion is a little bit more tricky in some circumstances, but the usual conventions that we use within the pancreas and other areas tend to apply in terms of nuclear pleomorphism, glandular epithelium in the wrong locations, rather than strictly the desmoplastic response. Distribution, we have sort of central duct and branch duct types of the IPMN, and size and issues there are important. Likewise, in terms of cytology, high-grade dysplasia is almost always going to lead to excision, independent of size, but sometimes just on the basis of size alone, surgeons may opt to remove these lesions. Okay, so staying nearby in the liver, we see a fair number of transplants. And it's really amazing to me how many patients are not completely worked up when they come to liver transplant. So here's a patient with a nodular cirrhosis. As you can see, we've got a sort of regenerative type nodule here, other more diffuse type nodules here with biliary ductular proliferation, fibrosis. Not a lot of remaining inflammation here. As you can see, there's not a lot of active inflammation remaining in this situation. As is often the case, we can't tell a lot about etiology just from the H&E alone. So typically doing a immunohistochemical stain, doing a panel of stains that includes iron, maybe copper, PAS diastase, and so forth could be useful. Even in end-stage situations, because oftentimes there are implications both for the patient in terms of recurrence, as well as for family members who may be similarly affected. So just a quick question on histologic findings in alpha-1 antitrypsin deficiency. The right answer here is this one, PAS positive diastase resistant cytoplasmic globules are present usually in zone 1, near the portal triads, so not zone 3. Okay, and with regard to the genetics of alpha-1 antitrypsin disease, autosomal recessive disorder, and these PiZ and PiS are the most common alleles. That's kind of picky question and so forth, but might show up on the boards. How would I tell this? The answer was here. Well, I've got sort of 2 votes for those 2 alleles. So I would choose, if I were guessing man, I would choose that it's got to be one of those. And then I'd have to decide based on what I know about frequency, whether it was more likely to be recessive or dominant to make up my mind. That's how I would game the question. So let's take a look at what these look like here side by side. We'll look here at first at the PAS diastase stain. And as you can see here, we may look normal here at low magnification, but you've got to go to a little higher magnification. And if you look carefully enough, you will see these nice PS positive globular deposits. And they can be of varying size, small to large. Here you see them kind of throughout the lobule. It's not perhaps the most characteristic finding, but most commonly they're here in zone 1, just adjacent to the portal areas. And certainly in a more normal patient, that's where you'd find them. But there are lobules where you don't find them. So if you have a regenerative process, you may have lost that capability or not be retaining that product. If we look at distribution in the with immunohistochemistry, This is what they look like with immunohistochemistry, and you can see there's a lot more here than maybe we detected with PAS. But again, notice that some of these lobules are relatively spared and don't have hardly any. So there may be some specialized areas of the liver that are more tuned on to producing alpha-1 antitrypsin, whereas a regenerative nodule may not turn on the genes to produce this product. And the fact that the antitrypsin is retained within the cell should give you a clue that the defect is not in the manufacture of the product, but in the release of the product into the circulation. Of course, other disorders to be concerned about with alpha-1 antitrypsin would include, you should remember that from medical school, of course, emphysema, as well as potential other disorders. All right, so in terms of liver disease, understanding the patterns of injury with different etiologies. So of course, cirrhosis is an end stage, but there are different patterns of inflammation, fatty change, toxins, and so forth that will give you somewhat different variant etiologies, Mallory's-Hyaline, those sorts of things. You should be familiar with the grading and staging protocols that are used for evaluating liver biopsies and hepatitis. Grading from 1 to 4, staging from 1 to 4, with stage 4 being end-stage cirrhosis. And then, of course, pertinent adjuvant testing and what you can learn from that. Okay, so here's another liver case sticking around in the liver. We can see here a area of distinct abnormality here, and maybe the marginal zone here of adjacent liver that's somewhat compressed, but does not look to be cirrhotic. So there's a first and very, very important clue that the background liver is not cirrhotic. And that, in the case of a primary hepatocellular tumor, puts us 99% of the time into the right diagnostic category of fibrolamellar carcinoma. However, looking at this tumor, it's really quite cellular, and we don't see necessarily broad bands of fibrous tissue. We do see some intervening fibrous tissue between the hepatocytes and so forth in areas here, but it's not very pronounced. We do, however, see very oncocytic type cytoplasm, marked nuclear pleomorphism to the cells, and so that appearance is certainly very, very consistent with fibrolamellar carcinoma. Recognizing that this is a tumor that can have some variation in terms of morphology. We often think of it as just forming these linear bands of lamellae of fibrous tissue, but here's a situation where that's not the most prominent feature. Now, to provide confirmatory testing, in most cases, you might want to do some search for the fusion gene, which involves PRKACA. And interestingly, although this is a fusion gene-driven carcinoma, it's very pleomorphic. So it sort of breaks that rule that fusion genes are related to fairly monotonous, non-pleomorphic tumors. Thinking about other things that you might use to differentiate this in the early stages, if you don't have access to that fusion gene testing, so you're not going to look for cirrhosis, or if you don't find cirrhosis, you should not be thinking about if you do find cirrhosis, you should not be thinking about fibrolamellar. In contrast to other hepatocellular carcinomas, the AFP is often not elevated, but we do often have this CK7, CD68 positivity. And these are two antibodies that are much more likely to be present in your labs, or you'll have access to them. Cytologic pleomorphism is helpful, but is not as discriminant as the immunohistochemical differentiation. So cytologic pleomorphism, a good answer, but not the best answer. So in terms of liver tumors, classification, differentiation, knowing how you distinguish hepatic from biliary, primarily based on immunohistochemistry and morphology, recognizing that there are some crossover combined forms, combined cholangiohepatocellular carcinomas and so forth, where treatment distinctions may be different. And of course, utilizing the appropriate tissue-specific markers for hepatic neoplasm, preferably getting some positivity with either HepAR1 or arginase 1, potentially glypican-3, and biliary tumors not having any of those markers, but usually expressing strongly a CK7. And for intrahepatic tumors, use of in situ hybridization for albumin RNA can be a very useful event as well. The molecular events primarily of interest with regard to the fibrolamellar variant that we just mentioned. All right, so coming back to the tubular tract here, we'll look at this stomach biopsy for a submucosal nodule. We see a little bit of lymphoid aggregates. Lymphoid aggregates are not a very specific finding. They don't really indicate gastritis, although they may sometimes be seen in the setting of prior Helicobacter infection, maybe a sort of resolving situation. So I would look around to see if I saw any evidence of Helicobacter in this sitting, and I might even stain it if I had very much that was superficial. But just on the basis of a lymphoid aggregate alone, I would not do it. Recognizing also that lymphoid cuffing can be present in a variety of mesenchymal tumors, and it looks as though here we do have a mesenchymal tumor. Lymphoid cuffing is very characteristic of schwannomas, and not particularly characteristic of GI stromal tumors. So certainly in this situation, I might do an immunohistochemical marker to look for schwannoma to make sure that that's not what I'm seeing. But I don't see Antoni A, Antoni B, Verrucay bodies, any of those other morphologic markers for schwannoma. So the usual immunohistochemical markers that we would do would include DOG1, CD117. We would probably also, in some circumstances, do a STAT6 to make sure we're not dealing with a solitary fibrous tumor, but also S100 and potentially a myogenic marker such as Desmond. So are there any syndromes? Which of the following is not associated with GI stromal syndrome? And that's a tricky, I mean, usually board questions don't use this all of the following but kind of structure. So this is really not a board style question, but Cowden syndrome is not associated with GI stromal tumor. However, these other syndromes or triads do have some association with GI stromal tumors. So be aware of that. In terms of workup, we've talked about that, differential diagnosis, molecular variants. It is important to recognize that it's not just c-KIT mutations that are associated with GI stromal tumor, but that you can also get it in association with, actually, let's go back here. I think I had a second annotation here. I guess I didn't save my my query. So it was a query on the workup. But PDGFR alpha, but also being aware that sexin A dehydrogenase mutations and so forth can also be associated with GI stromal tumors. And those may play into the role of resistance to certain of the targeted therapies that are used for GI stromal tumor. Okay, still here into the tubular tract, and now we're down into the area of the colon. As you can see here, we've got sort of random biopsies, a lot of them. Typically occurs in the setting where the patient has diarrhea and the endoscopist doesn't see anything, and so they say, hey, is there microscopic colitis? And this is a disorder that even at low magnification should jump out at you. So let's go back down to low magnification and see where are the clues. Well, here's an extra clue here, sort of pink along the subepithelial membrane, also here. So we're seeing a little bit of increased pink tissue. And also, these are all quite uniformly blue. The colon is diverse in terms of its normal distribution of inflammatory cells, having more inflammatory cells on the right colon and progressively fewer as you progress to the rectum. So seeing a sample where they're pretty much all bluish should make you think that there may be some inflammation going on. So in addition to finding this thickening of the subepithelial lamina, you should also be able to identify some evidence of epithelial surface damage. So let's see if we can find a, whoops, I guess we didn't find it here. I didn't tag it here. But there is a little bit of intraepithelial inflammatory cells here, some Karyorrhexis and so forth, that indicate there's been some degree of surface damage. Here's a little bit more. It's kind of subtle in this case. It's not everywhere. And so it's not a what you would call a rip-roaring microscopic colitis. It's kind of a smoldering microscopic colitis. And that may be why you're getting the collagenous deposition. But areas, yeah, look relatively normal. Trichrome staining will highlight the thickening here and help you differentiate this from just fibrin deposition. Maybe you'll want to do CD3 stains or others to highlight intraepithelial lymphocytes in areas like this. But if you need to do that, you probably are not going to have you're probably not dealing with the disease if they're not more obvious than what you would need immunohistochemistry to demonstrate. So let's take a look at our findings here. Classic histologic findings in collagenous colitis are, well, there's not lack of subepithelial collagen band. Diffuse lamina propria hyalinization with withered crypts, nope, that's ischemic. Congo red stain positive deposits around blood vessels, nope. Surface mucosal damage, lamina propria inflammation, and subepithelial collagen band highlighted by trichrome, obviously the longest answer and the only correct answer there. Our other question, the clinical scenario typically seen with collagenous colitis is a chronic intermittent watery diarrhea, oftentimes profuse, more frequent in females than usually elderly patients, but certainly can occur at other ages and other settings. Not usually associated with bleeding, not usually associated with endoscopic findings, not usually associated with pain. So all of those help you rule that out fairly quickly. So another disorder that can occur in the colon is characterized here. We see these really quite hyperplastic appearing colonic crypts and glands associated with this polypoid granulation tissue that's got wildly dilated vascular spaces, intense capillary proliferation, even to the point of having sort of angiomatous nodules here in sort of a capillary hemangioma type pattern, and then ulcer debris on the surface with ulceration of this granulation tissue. So this is characteristic of a granulation tissue ulcerated area, and when taken from the rectum or distal sigmoid is characteristic of the rectosigmoid prolapse syndromes or solitary rectal ulcer syndrome. And the most common frequent symptom of that is rectal bleeding. Yes, you can get discharge. You may be a little bit incontinent. These are much less likely. But rectal bleeding, as you might imagine, with an ulcerated granulation tissue like this, is going to be fairly frequent. Histologic findings that we tend to see: surface ulceration, some degree of fibromuscular hyperplasia may be present. We don't see a lot of that here. Sort of inflammatory polyp type changes can be seen, and distortion of the crypt architecture, diamond-shaped crypts. This is the features that you're going to look for. But typically I don't look for diamond-shaped crypts, although I guess you've got a little bit of them here. I look for the ulceration and the hyperplastic changes, along with inflammatory changes in granulation tissue in the syndrome. Now, this is fairly frequent clinically. My other video on this topic was for a long time a very popular object of YouTube searches, and getting more hits and plays than anything else on my whole channel, much to my chagrin. But anyway, that's important to know. So here's another scenario, another colonic lesion we'll talk about. As you can see, we've got the colonic type mucosa, a little bit hyperplastic, somewhat depleted in terms of lamina propria inflammatory cells. I mean, there's hardly anything here. So just at low magnification, I might suggest or suspect that this is an immunocompromised patient or potentially somebody who's been transplanted even. And I also see this ulcer So that further sets me up to think about possible inflammatory mediated diseases. And this came in with the question, rule out graft versus host disease. So what do we do to rule that out? Well, we look in the epithelial compartment to see if we've got evidence of crypt damage and lymphocyte-mediated apoptosis, cell death going on, which we can see in several areas here. There's another area over here. You can see apoptotic bodies and so forth present. So if you find just a few of these, this is very helpful in the right setting and the right time frame to suggest acute graft versus host disease. Now, going back to low magnification, this is not a disorder you can make the diagnosis of at low magnification. So the clues here are otherwise normal looking mucosa with maybe depletion of the lymphocyte component in the lamina propria. But if you find graft versus host disease, you shouldn't just stop there, because that doesn't necessarily cause this ulcer. And so you want to begin to be looking for other possibilities. Knowing that people are immunocompromised can lead to other disorders, including a variety of things like cytomegalovirus, herpes, and so forth that can be of concern. And so we're starting to see here a few larger cells, and we'll go here to one more. Here's a field where we've got two of these cells with perinuclear HOF, a large nucleus, maybe a prominent nucleolus in some settings. And so going forward to do the immunohistochemistry to look for CMV would be very appropriate. All right, let's review our MCQs, characteristic histologic findings. Apoptotic cells within the crypts, dropout, maybe ulceration, characteristic of GVHD in the colon. We haven't talked about GVHD in other organs. In the other areas of the tubular tract, somewhat similar. In the liver, quite different. In regards to principal target organs affected by acute GVHD, so this was supposed to be skin, gastrointestinal tract, and liver. So the answer is skin, gastrointestinal tract, and liver in that order. Heart, rarely affected. Lung, may be affected, but we don't typically see that, not where we find symptoms. So skin, GI tract, liver, those are the spots to be looking for it. Maybe I'll just edit this while I'm here. All right. Differential diagnosis that includes these cells. So cytomegalovirus, everybody gets that one. Okay, so we'll go on to the next slide. In terms of colitis, we talked about microscopic colitis. You also have obviously IBD-related colitis, and knowing and understanding those is important. For IBD, we occasionally use the GIBO scoring system in our laboratory, so being aware of kind of what makes the difference between GIBOs 1 versus GIBOs 4 is important. Presentations in terms of things like pseudomembranous colitis or microscopic colitis, those are important distinctions to be aware of the clinical story there. Okay, still in the colon, let's talk a little bit about tumors. And here's a colon tumor. We can see we've got colon mucosa over here. And then we've got this very solid looking tumor with sheets of cells, very kind of high grade nuclei, no gland formation of notice, lots of inflammatory cells here. And if we look around here, we'll see even lots of intratumoral mononuclear cells, kind of lymphocyte-like cells. So lots of tumor infiltrating lymphocytes. And here we see them around the tumor as well as some histiocytes and so forth. So this is a tumor that doesn't look like our garden variety colon cancer. Is it colon cancer, or is it a MET? Is it melanoma? Is it something different? All those things come into the differential: metastasis, melanoma, lymphoma. Certainly large cell lymphoma can masquerade in something like this. And then finally, medullary carcinoma. Now, the kicker here is that immunohistochemical staining of medullary carcinoma of the colon is not typical for colon cancer. So you usually think of CDX2 positive, CK20 positive as being the marker for colonic primary tumors. That's not what you see with medullary carcinoma. In fact, those are usually negative. So here, negative, and CK7 positive. Oftentimes, you'll also have calretinin positivity as well. So CK7 negative, CK7 positive, CDX2 and CK20 negative are what we should see here. So the answer actually should be different than what we've indicated here. So let's edit that one while we're here. Great tool here, but we want to make sure we offer good choices. All right. Which of the following are true regarding medullary carcinoma? Well, obviously this was a tricky one. The tumor infiltrating lymphocyte should tell you that this is usually going to be microsatellite high. And it does have usually BRAF mutations and a good prognosis. So it looks terrible, but it tends to do well or better than similarly staged conventional carcinomas. It does not have KRAS mutations. Those are typically present in the conventional carcinomas. So that's the distinction here. Not stable, microsatellite stable, it's microsatellite unstable. So there we go. Okay, so other things to know about colon tumors and small bowel tumors. Of course, classification, differentiation, one from another. Medullary being one of the most important subtypes, but there are other subtypes as well. Staging issues, of course, everyone should be familiar with those. Staging in terms of size, nodal function, and even less common staging issues such as microvessel density or tumor budding score and so forth. And then being aware of the implications of things like KRAS mutations, mismatch repair deficiencies, BRAF mutation, and other markers, the APC gene mutation, and so forth. Okay, just to sort of finish up, this is just a little fun case. Obviously, we have a colonic tumor here, and we've got something stuck onto the colon here that doesn't look like human tissue. We look around, it looks like it's got some inner structure and outer integument. And we look at the other pieces of it here. It's got a gut there. And we'll find the other piece here. It also has this nice gravid uterus, and here you see inside all of the eggs of this parasite. So this is one of the more commonly identified parasites, usually in the right colon, the Trichiura trichiureus, and characteristic features of that. Of course, anyone who does parasitology is going to know that it's a barrel-shaped egg with a pair of polar plugs at each end. And that's in contrast to other things like schistosomal eggs or cysts from other parasitic diseases. Treatment option for this organism: albendazole or mebendazole, praziquantel. Okay, other parasites that you might encounter: strongyloides, amoebae. These are also organisms that can affect the bowel. Of course, tapeworms. We usually don't see those in histologic sections, and then Giardia. Other infectious disorders that may masquerade as tumors or infectious diseases, granulomatous disease, especially around the terminal ileum, various other infections. Whipple's disease, you should be familiar with those and understand some of the pathophysiology of those infectious disorders. Life cycles of the parasites, of course, very critical to understand. All right, a little bit about polyps. Here's a representative polyp, this one from the sigmoid colon. And it's got a exophytic kind of villus-like architecture. You can see here it's kind of got long fronds here. And here's another one sort of over here with branching and so forth. This is perhaps one of the best examples of ectopic crypts that I have ever seen. Every one of these is a little ectopic crypt along the sides and edges of this otherwise villus structure. So given the villus architecture, the lack of any conventional dysplasia, this is a traditional serrated adenoma. So here's our question. Exophytic villiform configuration, hyperserrated architecture with ectopic crypts, plus or minus hypereosinophilic cytoplasm. So that's what you like to see. This does not usually have the serrated lumen contour because we don't usually see it in cross-section. That's more typical of the serrated sessile lesion. And then picket fence arrangement, hyperchromatic nuclei, that's more of a conventional villus adenoma. So in contrast to villus adenoma, traditional serrated adenoma usually includes MAPK activation due to BRAF mutation. So it's not an APC mutation. Those are conventional dysplasias, adenomas. Mismatch repair function can be seen, but more typically in typical serrated adenomas or lesions, whereas in the traditional serrated lesions, they've got constitutive activation of the MAPK due to BRAF mutation. So they've gone a little bit further than just having a small degree of mismatch repair. Here's another polyp, this one from the small bowel. And as you can see, well, we'll turn it upside down or turn it right side up here. As you can see, this one is pulling up all aspects of the small bowel into the polyp. You've got villus structures, you've got Brunner's glands, you've got these elongated villi here associated with this. And the characteristic feature here as we look in between is these coursing branching bands of smooth muscle. So recognizing that you have smooth muscle in here, in addition to the conventional stroma here down below, is a clue to identifying this as a Putz-Jaeger's polyp. So a patient with this type of polyp might have which of the following? Aha, well, everyone got this right. I'm just really pleased. These are associated with a STAC11 mutation in at least 50% of cases with Putz-Jaeger syndrome. Now, Putz-Jaeger syndrome should be screened for which of the following? Ovarian adnexal neoplasms. Other neoplasms occasionally can be seen, but certainly the most frequent are the SCTAT and the STAC11 adnexal neoplasm. So morphology, to classify your polyps correctly, understanding the underlying molecular issues in terms of which are beta-catenin pathways, which are APC pathways, what the role is of other mutations along the way, and the management implications of identifying certain types of polyp. Usually it's going to mean increased frequency, unless it's a complicated or advanced polyp, in which case it's going to be much more frequently and may require excision. All right, so to sort of finish up, we'll cover a few liver disorders. Here is another end-stage liver. Here we don't see big macro nodules. We do see a lot of fatty change, some fibrosis, biliary microtubular proliferation. And if we were to come in a little higher here, we might be able to identify some pigment, maybe some cholestasis. Here we see the cholestasis. And then here we see some eosinophilic deposits, which I think you'll appreciate as a nice example of Mallory-Denk bodies. So a patient with this type of alcoholic steatohepatitis and cirrhosis might be expected to have elevated liver enzymes and alanine aminotransferase in a ratio greater than 2. Typically do not have quite the same involvement of GGT, which more typically reflects biliary mass lesions or dysfunction of the biliary tract. Okay, and then another case, this a liver core biopsy, another liver disorder that you should be familiar with. And here we see the type of portal tract inflammation, some damage here along the limiting plate. And as we look at this inflammatory infiltrate, your eyes should jump to and pick out the plasma cells. There are several plasma cells in this field, and sometimes you might even be able to find an eosinophil or two as well. They don't light up quite as well on the digital slide as they do under your own microscope, but they're there. And so which of the following, let's go to this, do you identify in this field? Plasma cell-rich portal tract inflammate and interface activity. That was that first question. And then we'll go to the next field. There you can see more of this plasma cell-rich inflammatory process here. And then one more. It even involves the lobules as well. So it's a mixed portal and lobular pattern with lots of plasma cells and a mixture of eosinophils. So based on the morphologic findings here and negative viral serologies, the best diagnosis would be autoimmune hepatitis. And that's characteristic of that inflammatory pattern with mixed inflammation and negative serologies. All right, one more case here to look at. We have a trichrome stain. And I really show you this primarily to just illustrate one major finding, which we'll go to right here, which is the presence of just beautiful chicken wire fibrosis. This pericellular fibrous reticulin process here is very characteristic of early stage steatohepatitis with fibrosis. And so that finding and recognizing that finding is very, very helpful. A good trichrome stain can take you a long way. You do see here, however, that we've also got some ballooning degeneration in these cells. And so this is what ballooning degeneration looks like on a trichrome stain. Here you see a little bit more of the ballooning in conventional areas and more here as well, a little bit more clear cut, but plenty of ballooning around. So understanding the staging frequencies for steatohepatitis, steatosis, lobular inflammation, ballooned hepatocytes, most prominent in zone 3, but also can see elsewhere. Here we saw them in the zone 1 with chicken wire fibrosis. So that would be your correct answer in this case, and what you should be thinking about with steatohepatitis. So to conclude then, we haven't covered everything. There's more on the web and more coming. Just to make you aware of that, I hope you'll visit the playlist and get some more good things out of that to help you prepare for your exams. So thank you so much for joining me. It's been a pleasure to be with you, and I look forward to next time welcoming your questions, and always welcome you to subscribe to my channel, hoping that it will be of benefit to you in your learning and practice of pathology. So until next time, thanks for joining me.